Well, welcome everybody. My name is Mark Lever. I'm Chief Executive of Helpforce, and I'm absolutely delighted that so many of you have chosen to join this UK-wide live chat, giving us all an opportunity to look back and reflect on the impact of COVID across the UK, what lessons we've learnt, and how we might take some of those lessons forward to help us prepare better for winter pressures, because there's obviously some parallels with the challenges that we face around winter pressures, but also the possibility of a second spike in coronavirus as well. So really important topic to discuss. I need to mention to all of you that we are recording this session, and we will also be recording the conversations in the breakout rooms as well. So it's important that you're aware of that. Can I ask you all to mute yourself as well, please, just so it makes it a little bit clearer when our individual speakers are talking to you, that you don't get all of that background noise. And I'm delighted that we've got Fiona Liddell from Wales, George Gillespie from Northern Ireland, Jane Fox from NHS England, and Alan Bigham from Scotland, who are going to be our speakers today. There's going to be lots of opportunities to have a Q&A session amongst yourselves and with them, so you can share your reflections. This recording is going to be shared on the Learning Zone, so if you've got colleagues who are unable to make this, or if there's things you want to go back and listen to, then it will be available on the Helpforce Learning Zone. It's important to note that the chat function isn't available. We're using Microsoft Teams and we haven't got the chat function available. So if you'd like to ask a question, raise your hand. Now that's not raise your hand on the screen, because there's so many of you, we won't be able to see you if you raise your hand on the screen. It's actually use the raise your hand function on the bar below the slides that you can see now. And CJ, who will be monitoring all the raised hands, will make sure that you're invited to speak. And when you are invited to speak, you'll have to unmute yourself. So just remember that. I think by now most of you are familiar with the drill on that. So we've got our agenda for today, and we're going to be quite strict on sticking to time, because we appreciate that you're all giving up about an hour and 20 minutes of your day. We know you're all incredibly busy, and we want to respect that. So our speakers are going to stick to time, and the way we organise the breakout rooms, we're going to stick to time. So we've got a little introduction now, which is what I'm going through, and then we'll have 20 minutes with our four speakers from the four countries, sharing their reflections on how COVID's impacted each of their countries, and a little bit of about their future plans to respond to possible second wave and winter pressures. We'll then have 10 minutes for questions and answers, and then we're going to give you all an opportunity to join the breakout rooms. You should have received instructions on that. So you'll be split into 8 breakout rooms where you can have further discussions. Each of those breakout rooms will have a facilitator, and so they'll take you through the agenda. And what we'd like to have at the end of those discussions and feed back to the group as a whole is one thing that you as a group think you'd like to carry forward. Those volunteering roles that were perhaps stood down that you'd now like to resume. So of the, if you like, old volunteering roles, which ones would you like to resume going forward? Any insight into your own trust's plans for response to a possible second wave or winter pressures? And how do you see your own volunteer service helping in that plan moving forward? So quite a lot there to focus on when you're in those breakout groups, and obviously we want the facilitator to make sure that the conversations are focused, so we can get that feedback at the end. At 1 o'clock, we're going to get all of you to come back to the main room and share those action points, and then at 1:15 we'll wrap up and we'll finish. So that's where we're at. So if everybody can go on mute except for our first speaker, which is Alan, who's going to share his reflections on how things have been in Scotland. So I'm now going to hand over to Alan Bigham from Scotland.
Thanks very much, Mark. Hello, everyone. Thanks all for inviting me to speak. I'm going to do my best to paraphrase some of the learning that's come from NHS boards in NHS Scotland. So I thought I'd start off just with this. This is our definition of volunteering. It comes from our national outcomes framework, and I wanted to start off with saying just what a huge, overwhelming response and how positive it was in terms of people stepping forward to volunteer. And the key thing there is people weren't motivated by financial gain, wage, or salary. It was because they wanted to give. And I'm pitching that to begin with because we need to retain that positivity, although there were some lessons learned from the experience. In terms of our volunteering in NHS Scotland programme, the first thing we had to do was reprioritise our work. So there was guidance that went out to ensure the safety of volunteers. We put together an online induction module from existing materials, and the fast tracking of volunteer recruitment was a key priority for the handful of NHS boards that were wishing to continue recruitment. And the key thing for us was we were already running an improvement project on volunteer recruitment, and some of the barriers around bureaucracy and delays and things like that, we were coming up against what seemed like some brick walls. So some of those have shifted now, I'm pleased to say, and there's definitely learning there as we progress. We also recognised we needed to spread practice and communicate more rapidly. The big increase that we had in our sort of inbound requests to our support and advice function showed that we needed to find another way of working during the kind of crisis peak period. So we ran some online webinars and allowed people to share practice at a strategic level, but also at an operational level. There was also a need to update the guidance on a monthly basis. So that's been something that's progressed over time. And we contributed to the development of the emergency volunteering leave scheme that was in the emergency legislation in the Coronavirus Act 2020. So that scheme is currently paused, thankfully, but should workforce levels reach some sort of crisis state, then that would be something that might end up being enacted. That's just a graph to show the kind of the trend in our advice and support function there. So the kind of rolling average there with 123% increase in demands on us in March in that one function that we run. In terms of the impact on NHS boards, the national recruitment campaigns, and this is where I pitched the positive to begin with. This is where it's slightly more challenging, but I do need to be quite upfront about this. That the boards weren't engaged in these, and that resulted in a few issues. One of which was a lot of unmet expectations. So I'm talking to people who understand volunteering here, understand role definition, and all the processes that are required to place, train, support, and retain volunteers. But what it set off was, the goodwill and good intention, but there wasn't really the demand at a local level within NHS boards for that volume of people. There was also a lack of clarity in terminology, and some of that was challenging around the mixed messaging of volunteering. So when even statutory bodies were talking about placing people who are paid into other roles to support other parts of the service, some people were calling that volunteering, some were calling it redeployment, and it was actually neither. So that there are some issues there about we need to maintain the integrity of what we mean by volunteering, and we need to keep our eye on that as we exit from this whenever that happens. The most obvious impact on boards was the volume of applications. So even if you have a clear pathway with a website that says you must register here to volunteer, the high volume of inbound calls, emails, and requests and offers from the public was something that volunteer management teams had to deal with locally. So that volume of people, that led to some of the fast tracking of recruitment and removal of some of those barriers I said around the recruitment process. And obviously there was an increased focus on risk and risk assessment. Some roles have adapted. So for example, spiritual care, breastfeeding, listening services done over the phone or remotely. Public involvement roles largely stepped down but might be done virtually, and the wayfinding roles and volunteers and more focused on the hygiene element, understandably. And new roles, the most obvious being the donations and belongings transfer. Other roles largely supporting staff and more things in the community, some things that already existed, but again, perhaps with a higher profile. So key bits of learning, engagement from the start, particularly with national campaigns, very taken by the point, Mark, you've made there about winter pressures and second wave. So there's an opportunity to reflect on these campaigns and make sure we get it right. Some key messages there that you could lift directly from our ongoing communications were the volunteers not expendable, don't replace the work of paid staff, and the support needs to be planned. And lastly, again, I'm sure there'll be anyone on the call that disagrees with this, that the robust and sustainable volunteering programs require adequate investment. And the last slide here, I just wanted to share, these are a couple of examples of unsolicited feedback. So one on Facebook of someone who was singing the praises of volunteers who had passed on belongings to the father, and another example of somebody sharing the same for the mother, thanking the volunteers for the hard work that they did.
Thank you so much, Alan. That was brilliant, perfect timing. 5 minutes, bang on the nose. So we'll have our 4 speakers first, and then have a Q&A at the end. So we'll now head over the Irish Sea to George Gillespie, who's going to give us the view from Northern Ireland. Over to you, George.
Okay, thank you, Mark. Very fast jump over the Irish Sea, as we say. No boats, no planes. I concur a lot with what my colleague Alan has said from Scotland. I'm just not as precise as Alan in terms of having slides, so you'll just have to listen to my dulcet tone. Northern Ireland, in terms of volunteering, 95% of volunteering within the National Health Service in Northern Ireland was actually suspended. The reason for suspension, there are many reasons, but one of them being that 30% of the volunteers in Northern Ireland who volunteer both in an acute setting and community setting are of the age 70 plus. And with that comes high risk. Some roles did continue, and some roles did actually change, very similar to what Scotland have done as well. The peer support breastfeeding continued. Befriending that would have previously been face-to-face became virtual. That was basically virtual through telephone or indeed through iPads on wards. Very, very few volunteers actually practically within a hospital setting. Indeed, actually, there was none, right down to pastoral care. Pastoral care would have been carried out by the chaplains virtually. That they did not allow anyone. In Northern Ireland, we have 7 trusts because we are combined health and social care. Our Northern Ireland Fire and Rescue Service is also included under Department of Health, as is the Northern Ireland Ambulance Service, along with the 5 other trusts. In terms of learning, the learning and moving forward for the potential winter and second wave, the Department of Health in Northern Ireland have very much not offered guidance to each of the individual trusts. They're letting the individual trusts make their own decisions. However, the guidance around that is that all roles that are being reintroduced into an acute setting in Northern Ireland must be revisited. The risk assessments must be revisited, and that's looking at infection control and basically control measures. Now, the Belfast Trust have actually just reintroduced meet and greet, and they noticed that because patients were allowed to have visitors coming back into the hospital now. But basically what the Belfast Trusts have done in all of their acute settings is they have a little bubble, a perspex bubble, where the volunteers will stand behind, and they will guide people from that. There is no direct face-to-face contact. Some of the trouble also has been PPE, which is widely known right throughout the UK. And unfortunately, as is always the case, volunteers are very much down the pecking order when it comes to PPE, but that is starting to come through now. Some of the community roles that continued and will continue are the delivery of food parcels, delivery of prescriptions for those shielding. But really, in terms of moving forward, Volunteer Now chair the Health and Social Care Forum here in Northern Ireland as the lead organisation in terms of good practice around volunteering. So working with the trusts at the moment, we're looking at the updating of role descriptions. We're also looking at a new recruitment campaign because potentially 30% of our volunteer army as such here in Northern Ireland will not return to volunteering because of the high risk element there. We very much like Scotland had very much unmet expectations. We had over 4,500 people in Northern Ireland who put themselves forward to volunteer for the National Health Service, and that more or less came off the back of the national campaign that Westminster launched. However, it was launched in terms of Northern Ireland ran their own campaign because the expectations we feel have not been met by volunteers or by organisations and volunteers. So we need to be very careful moving into the future in terms of meeting those potential new volunteers and their expectations. There will be new boundaries and new expectations in terms of volunteers volunteering within the National Health Service. They will have to be more aware of the risk assessments, health and safety guidelines, insurance. What we're finding in terms of volunteering as a whole here in Northern Ireland is that a lot of insurance companies are not actually covering 70+ volunteers due to the risk of COVID, and a lot of organisations are potentially having great difficulty with that. PPE, screens, signage, all of that has to be looked at, and it has to meet the requirements of the Department of Health guidelines. And we're also looking at a new induction to try and cut out some of the bureaucracy. So that will be online registration forms and indeed online inductions. So that's really an update, but currently we still sit in Northern Ireland with 95% of our volunteer roles in the National Health Service suspended, and that is looking like it probably will not be reintroduced until 2021 due to the potential of a second wave. I hope I was on time, Mark.
You were just about actually, George. Well done. That's really good. Thank you for that. And we're now going to head over to Northern England to Jane Fox from NHS England, who's going to give us a perspective from England. Thanks, Jane.
Hello, thank you everyone. Thank you for this opportunity to talk to you all about what's been happening in England. So really very similar in terms of the way that COVID has impacted and affected volunteering services across England. Similarly, a lot of services were suspended and stood down by NHS trusts immediately, and then roles were reintroduced. So from a sort of a national perspective, we very much recognised there was a need to get some guidance out as quickly as possible, and obviously all the guidance that we have put out has been reflective of the kinds of issues and questions that trusts were facing out there, and everybody trying to address the same challenges. So things around fast-tracked recruitment, how you deal with sort of people who want to continue and the risks to health, etc. So we put a lot of guidance out around that. We took advantage of opportunities to look at passporting in terms of the onboarding process and managed to negotiate a short-term arrangement for individuals to be passported between NHS organisations. So one onboarding system enabled them to be moved elsewhere to support things like the redeployment. We also, as has been mentioned, had a sort of a national response in terms of supporting the shielding population. So I think this is where NHS England has probably made the biggest sort of media interest has been around the role of the NHS volunteer responders, and they were very much put in place so to enable the shielding population to be supported through this period where they didn't have friends or family nearby and where there were challenges. So the volunteer responders has sort of enabled us to look at volunteering quite differently and look at micro volunteering or task volunteering. So rather than someone giving their time continuously on a regular basis, they've been able to say, I'm free now, what can I do to help? Again, like many of you have sort of alluded to, there have been unmet expectations. So people were expecting to do a lot more, and we were flooded with offers and not necessarily the tasks. And you know, with COVID, it took quite a long time to get the tasks and the referrals coming through. So that's been some interesting learning, and it's one of the things we're looking at now is what's the legacy for that? So what potential is there for micro volunteering to continue into the future? We also, I suppose there was a lot of activity nationally in terms of looking at workforce and bringing back staff, and very much have tried to think about the role of the volunteers within that context. And also we had quite a lot of national activity looking at the corporate offers that were coming through, and we've had corporate offers of, you know, sort of the same things that many people have had. So laptops, the tangible things, what, you know, where could they use iPhones or iPads to support systems and trusts with challenges through COVID. But we also had quite a lot of corporate offers of people, resources, skills, etc., where there's been opportunities to try and look at how people who had been furloughed, for example, or had got capacity could help out. So one of the examples of those is Project Wingman, where the air sort of lines have provided staff in various trusts to provide that rest and respite for people, for staff under pressure. In terms of the current focus going forwards, we're very much still focused on how we support sort of those vulnerable people going forwards through into the winter pressures, from the COVID perspective, but also the winter pressures perspective, which we know is coming, and the role that volunteers may play in that. We're also very aware that there are, you know, potential local lockdowns and how we can continue to be responsive within those areas. And a lot of the sort of activity has been around the response to COVID and what that means going forwards into the winter pressures situation. Notwithstanding, at the same time, we've got lots of our NHS organisations looking at restart and recovery plans and what roles and how they retain, you know, the things that have moved at pace during COVID, and, you know, some of the challenges that have been overcome and resolved. How do we keep those? But also, where are the barriers? Where are the challenges? The things that we still need to address going forwards. So I think we've still got a lot of activity on, was trying to support restoration of services as far as we can with national guidance, but there is also that ongoing challenge of resilience and responsiveness and how we balance, you know, sort of the NHS volunteering offer and make sure that that's integrated with community support. So I'm probably just gone a little bit over there, so sorry for that.
No, that was really good, and I really appreciate everyone trying to stick to their time. It's a fairly tight schedule, but no, thanks, Jane. That was great. And last but not least, along the M4 into Wales, we've got Fiona to give us a view from Wales.
Mute myself. Good morning, everybody. Good afternoon, everybody. Thank you. Much of what I want to say, you'll have heard some of the themes already from elsewhere, but it's still worth saying. What I want to do really is to touch, first of all, on some comments on the general volunteer response, and then to focus a bit more on the NHS response. And I think it's worth just flagging up, but I won't say any more about the role of other voluntary organisations like Blood Bikes, Red Cross, St John's and so on. We've been developing case studies and some amazing work that they've been doing. I just want to give you a little bit of an overview and then just to flag up some of the learning points that have been coming out of the last few months. In terms of the volunteer response, as other people have said, overwhelming response from volunteers. I mean, quite remarkable. Our national comms from government and media sources directed people to our Volunteering Wales website. We have one bilingual All Wales website, which is managed by the county voluntary councils and is used by statutory as well as voluntary organisations. And every county put onto that a COVID-specific opportunity, which was of a generic nature, and this was as a way of quickly onboarding people, doing preliminary checks, and to enable flexible deployment at a local level. That was a good thing. The CVC broker function then kicked in and has proven its worth, enabled some good collaboration locally. At speed, the developers of this app website developed for us a new app which enabled managing of tasks rather than fully fledged, more formal roles. Great idea, done at great speed, lots of lessons learned in that there was a lot of resistance to trying it. It raised too many questions that couldn't be asked straight away. It wasn't the kind of volunteering that the website normally managed. 3 areas have been trying it out with great success, but in terms of future preparation, I think we will be looking at how we make use of that task and the embracing of the idea of micro-volunteering in the future. The NHS Responders Scheme was not rolled out in Wales, partly because we have this structure, this infrastructure and the potential of this app, and it seemed sense to go with that. Key learnings then, again, volunteer offers outweighing the opportunities many-fold. Many of those volunteers we know, 30 to 40%, we reckon want to continue volunteering. So question, how do you maintain the interest of these volunteers? Community groups, not just individual volunteers, but unprecedented growth in community groups. They have proven their agility, the informal, place-based, flexible nature of what they do. Question for the future, how do we sustain these post-COVID in ways that don't destroy them by trying to turn them into something formal and constituted? And how do we link them in with local infrastructures that can, you know, support and coordinate as appropriate? The national website that I mentioned was described as a godsend. A question for the future is, how do we develop that? Both to enable more informal expressions of volunteering. I alluded to the task-based approach, but also how do we increase its usage to give us a better national picture and insight. The fact is that as well as this website, people had their own systems, and at least in one case, people were developing their own website. So it isn't a reliable national picture of volunteering by any means, and there is potential that could be developed there. I think another lesson from this side of the work would be the need, strong messages about the need to co-produce solutions. We have many wonderful examples of problems identified, like volunteer ID, cash handling, delivering pharmacy supplies and so on, and ending up with solutions being devised at national level and at local level, behind the local solutions, and a lot of kind of frustrations and miscommunications and duplications happening because somehow we hadn't kind of had the right conversations at the right time and be clear whose solutions were going to be taken up. Really interesting. So volunteering within the NHS for the last few minutes, very varied between health boards. Some stopped all volunteering, and those tended to focus on the well-being of volunteers. So they didn't stop activity, but a lot of keeping in touch with volunteers who themselves are going through a difficult time, and they're making use of something, you know, one health board called chatter lines, so online means of volunteers communicating one another for peer support. Some took that kind of workforce approach. So everything paused, but then everything was reappraised, new roles redefined, classified according to risk, and waiting to see, you know, what needed to be done and by whom, and volunteers were into that mix. Has to be said, as others have said, very often requests for volunteers through that kind of scheme were very low, much lower than the availability of volunteers who were being prepared for these agreed roles. One of the examples of agreed roles would have been in the field hospitals. Quite a lot of volunteers were ready to help the staffing mix of the field hospitals, which haven't been used to date very much. A lot of adapting roles then, as others have mentioned, befriending, driving, delivering PPE, food parcels, telephoning, pharmacy, gardening. In many cases, that was just a reorientating, a realigning of the kind of activities that were going on before. Growth in roles that were to do with sort of patient experience and community liaison, sorting of donated goods. Interesting role I heard was about liaising with families about the personal possessions of people who had died when the family were self-isolating and couldn't come in. So volunteers were getting involved in the delivery back to the family of possessions that belonged to their loved one who had died. Sewing groups, letter writing, and so on, enabling contact between families and hospital. And then lastly, another important approach taken by health boards to different degrees was the working closely with community partners, with their county voluntary council, at least in one case, very closely working with a memorandum of understanding, a kind of joint system for recruiting and supporting and training and deploying volunteers who were largely involved in the community, but there was the potential to involve them more in community hospitals in a rural area. No shortage of volunteers anywhere. Couple of learning points, just watching the clock here. One, I think it's much easier for health boards to redeploy existing volunteers than to be managing new offers from new volunteers. And I think that's a message to take forward in terms of building resilience, a more agile volunteer force, if you like, streamlined processes, agile focus, having people on board already makes it much easier then to respond to crises in the future. How do we tap into that larger volunteer public resource? Either directly or by working with partner organisations is another question. How do we manage public expectations, which are often unrealistic and not always helped by the high profile media, is another lesson. For us in Wales, I think the priorities are that we need more opportunities to learn one from another as health boards, and we're hoping to address that with an event in the next month or two, and needing together to have those conversations about how we develop thinking about volunteers, how they can support the NHS, and how we can create also better pathways for volunteers, picking up Jane's idea of the sort of mobility from one organisation to another, the passport idea, but also giving volunteers the opportunity of experience, and bearing in mind that at this time many young people's education has kind of come a cropper, as opportunities for real experience is something that they as a sector of our population are quite hungry for. I'll pause at that. Thank you very much.
Thanks very much, Fiona. And thanks to all four of our speakers. And it's worth noting that, you know, as people have flagged some very specific and innovative volunteering innovations, that the big thank you, which Helpfuls have launched over the last few weeks, is really designed to give everyone an opportunity to highlight great volunteering over the last few months, well, over the last 12 months, but specifically around COVID. And if you do have any nominations that you want to share to celebrate, then we would be really happy to receive those nominations and put them on our wall of fame. So there's details on the website. We've got a few minutes before we go into the breakout rooms for any quick questions. Obviously, you'll have more of an opportunity in smaller groups in the breakout rooms to talk. But does anybody have? Is it the one or two people who've got a question they'd like to ask now before they go into the breakout rooms? CJ will manage this. If you've got your raise your hand, CJ will invite you to speak, and if you unmute yourself, we will all hear you.
No problem, Mark. So I'm just scrolling through the list. We did have Rebecca Adams had her hand raised, but then it did go. So Rebecca, did you want to ask a question if you unmute yourself?
So sorry, I think that was a mistake.
Oh, No problem. Next, we do have Amanda Cleaver. So, Amanda, if you want to unmute yourself. I don't know if Amanda might be experiencing some issues where the unmute button might be on the control panel.
She looks as if she's muted at the moment, but she's got her hand up.
Yeah, unfortunately, we don't have the... Oh, there we go.
Sorry, everybody. Can you hear me now?
Yes.
Yeah, sorry. It would have been interesting just to have heard a little bit more data around the NHS responders, you know, because there's a lot of publicity about that, and obviously just the, you know, the mentioning about the confusion that we had at the beginning, and I'm sure other NHS trusts were the same, that, you know, we had a lot of public ringing us to say, oh, are you the NHS responders? And that was quite a bit of time on our hands. But I think it's interesting, isn't it, you know, just looking at the success of the NHS responders and the contribution they made for the community, but then looking at the decimation that happened in the NH for the volunteers and the hospital trusts. And, you know, Northern Ireland has mentioned, you know, 90%, you know, step down, and it was the same for us. We had a huge amount of volunteers step down, and you know, we've just been looking at a bit of sort of figures around that and some costings around that, and you know, I'm looking at, you know, we're trying to get back to our places before, and we're looking at a costing of around, you know, 40,000 to get our volunteer service as we were back before, and we've had a huge drop in you know, unpaid value. You know, everybody does their hours of contribution that volunteers brings, and at the moment we've got a 23,000 drop in unpaid value to our service. So, you know, the NHS trusts have got a huge amount of work on their hands, and yeah, we just need some resource. But really interesting hearing from other areas. So thank you.
I think it's a really good point, Mandy, and the research that we've done with yourselves, you know, VSMs, and looking, you know, talking to trusts more widely and systems more widely. I think whilst there's been a massive uptake in volunteering within communities, as you say, there does seem to be a significant decrease in the level of volunteering within hospitals themselves. And one of the concerns that we've had is that actually whereas the view is that coming out of COVID, actually volunteering has moved on a stage, our feeling is that when you look at in-hospital volunteering, it's actually gone back. And there are real concerns, I think, when you look at winter pressures. And last year, when there was a big focus on trying to increase volunteering within hospitals to respond to winter pressures, that actually we're starting from a much lower base going forward now. And I think, you know, we're looking at ways in which we can try and support VSMs to make a stronger case for getting volunteering back on track. Because actually the research tells us that it isn't the volunteers who are nervous about coming back into hospitals. It's more around the senior leadership within the trust actually deprioritising volunteering at the moment, which is part of the issue. So I think it's something that we're really keen to support VSMs with going forward. Mandy, did you want to come back?
Sorry, yeah, Mark, sure. I just wanted to say, you know, absolutely correct, you know, but also just not to miss, you know, the NHS volunteer contribution to COVID, and ours was pretty outstanding and surpassed ourselves, and you know, redeployed volunteers, you know, sort of 30 new roles, all in a very short turnaround time, and so I think there's great success there. But just obviously we've got to build up our workforce again.
Yeah, I agree. I mean, there were some fabulous in-hospital recruitment campaigns where hundreds were recruited at very short notice. So no, that's very good. We'll start. So thanks everyone for taking part in those breakout sessions, and thanks to the people who are facilitating. For the purpose of everyone, notes were taken in all the meetings, and so all the content's going to be shared on the learning zone. But I thought it'd be helpful before we wrap up, just have a very quick summary of the main points that came out of the discussions, and by very quick I mean like a minute. So let's start with the person who was facilitating in breakout room 1. So
Alan,
if share feedback. So Alan.
Yeah. Hi there. Thanks,
Alan.
Hopefully I'll do my best to summarise. So in terms of things carried forward, pretty overwhelmingly and not really surprisingly, the streamlined recruitment process, so realising that the barriers that were there and the proof in the pudding that they were able to be removed has been very much a positive piece of learning that people want to carry forward. Also recognition of how volunteering can be a launchpad into work, career and social care, and it was quite rapidly done. There was an example of leading on cross-sector collaboration, so structures that weren't previously in place but have proved to be very valuable. And another key thing was the remote volunteering as an option. So rather than just the services that have moved to telephone support moving back to how they were, but retaining that as an option both in the one-to-one type of support, but also an example of a group-based support. In terms of roles, like to resume, it kind of linked to the next stuff about the second wave and winter pressure, that that just recognition there's a lot of people still want to return to volunteering, but it's also a large volume of people that expressed an interest, so that needs to be carefully navigated. And there was a key point brought up about maybe some assumptions from external statutory partners around mutual aid. And anyone who's worked in the third sector will know that sometimes there just can be these assumptions that the third sector will pick up everything. That now seems to be that mutual aid networks will pick up everything. So some key points made there about people have had the availability to volunteer, either been furloughed or had the impetus to do it, but they may be tired, they may be exhausted, and they may not be available going forward. The last point, which kind of linked to just the volunteers, which was more kind of internally focused about ensuring people are supported until they return. So examples of Zoom calls and contact with volunteers, and mention of the NHS England recovery framework, just in terms of having some of those discussions for volunteer managers to have those discussions with volunteers.
Brilliant. Thank you very much, Alan. That's a great summary. If we move on to room 2, I don't know who was.
Yeah, it's Ross, please.
Roz, you're on mute, I think, Roz.
Yeah.
Right. Can you hear me now?
We can now,
Thanks.
loud and clear.
Right. So on question 1, we the things people would like to bring back was, one of them that came out very strongly was the webinars from Helpforce, to have this group of still talking together and being able to share problems and just, I think, communicate to each other. Scotland very much about the online inductions, which have gone down very well, and that's made a big difference. So that was really good to hear as well. And it was about things online and how we can get more done online. The 2, I think, projects that they would like to bring back are volunteer projects where recycling, very strong on recycling and volunteers taking away walking aids and different things, furniture, benches, and disinfecting them and then bring them back. So that's quite a cost saving to the trust. So to bring that back, and pet therapy, a big thing for, well, ordinary hospital acute wards, but also mental health trusts. So that would go down really well. The third question, what are your trust plans for the second wave and winter pressures? There's still a lot of thought going around this and nothing in place yet. They would like more direction from senior leadership on this and would like to be consulted around it, so to have more discussions around what they can do to help and offer. And how do you see the volunteering service helping that plan? So I'm sorry, I'm looking at my notes here and got mixed up there. So yeah, that was the same thing. They'd like to be consulted. What came out of it as well, that the recovery plan and restart plan that NHS England did was very good and actually has started some conversations in the trust. So it's actually making leaders now take note of that, and because they need to obviously look at, should they do risk assessments? Do they do them? Do they not do them? And then one thing I think to mention as well that came up, and I don't know if Jane could maybe talk about this at the end. I think it was George from Northern Ireland mentioned insurance for volunteers over 70, and obviously that's raised a question in our group about what happens in England. So if that could be addressed later, that would be lovely. Thank you.
Thank you very much, Roz. Thanks, Roz. That's great. I think we'll need to go back to Jane and ask her, because I think she had to leave us at 1 o'clock to go to another call. So we move now to group breakout room 3. I don't know who was leading that. Yeah.
That's the group you were in, Mark.
Was it really?
Yes. 3 points we can just pick out, things that we'd like to see taken forward in planning for the future. how they had set up a system for volunteers to follow up by telephone with patients who are being discharged, patients who are being given sort of discharge bags of essential items, and volunteers doing these follow-up calls to check on their well-being, and with mechanisms then to sort of feed that back to other appropriate contacts in the community. So something that's been initiated that they hope will continue. It talked about the potential for developing training, not just training that's kind of clinically focused and sort of do's and don'ts kind of thing, but stuff that invests more in the volunteers, looking after their own self-care, building their own understanding of the kind of role that they have to play. And this was particularly in relation to bereavement, but that idea of building up training that helps the personal development of volunteers is an idea that I think will be taken forward. And a third area was about the opportunity now for revisiting those conversations with senior colleagues, engaging staff and senior colleagues about volunteering, about questions of risk, about the potential of volunteering, the contribution that they make to the hospital, to the workforce, and particularly to the well-being, health and well-being of staff, as well as to clinical outcomes, and the way in which volunteering can enable us to build not only a more kind of resilient but a more diverse workforce. So perhaps revisiting some of the kind of arguments and conversations that we've been having about the kind of case for volunteering in hospital and NHS work.
Great stuff. Thank you, Fiona. Moving on now to room 4.
Yes, Beth, please.
Hi, yes. So our group was slightly different. We had 2 STPs and one of our services wasn't able to bring the volunteers back, so it was a different focus discussion. But some really interesting thoughts came out along the lines of micro-volunteering and task-based volunteering and how to bring that forward, which allows for a different type of volunteers to get engaged across trusts. And that's obviously something that's been triggered with the mutual aid groups and things. How to integrate volunteers now. There was an interesting conversation about how clinicians and people are actually missing the volunteer role. So it's them that are saying, you know, where are our meet and greet volunteers? We need to get them back. There didn't seem to be a lot of certainty around planning for winter pressures and a possible second wave. And I think someone said earlier, it'd be great to, I think it's important the volunteer managers are engaged with those discussions now, but there's a huge uncertainty around how to keep volunteers safe. The other thing that's gone well is in one of the services, a lot of the volunteers are now looking at possible careers in healthcare, and it's very clear that the experience that they're developing through volunteering is being used to help with their CVs and their training and to apply for jobs, and the quality of volunteers is changing and improving. But in the interest of time, I think that's probably all to add at this point, but we'll write up the notes for everybody.
Great stuff. Thank you, Beth.
Okay.
Moving swiftly on to room 5.
Hello, room 5. Oh gosh, am I there? Sorry.
You are?
Oh, hello. Right,
Loud and
so
clear.
for us, similar to group 3 around our the discharge check-in, volunteers has been very helpful, particularly for our trust, but I recognise for other trusts. One of the challenges for that role is it was suggested that about the information governance agreements, and we've certainly had some challenges around data protection impact assessment that needs to go alongside if we're working with outside bodies who are on volunteers who are phoning our patients, and how to keep there's information safe. But also there's been some interesting developments around chaplaincy, radio links with one trust where they've linked promoted radios as an opportunity to get podcasts run by chaplaincy, because we can no longer get the chaplaincy volunteers onto the wards. And with regards to moving forward in plans, similarly to everybody else, there's nothing really been in place, but a recognition that would be really helpful to be linked into existing trusts, transformation plans and planning groups to make sure that volunteer services are embedded in those plans in some way. I think I'll leave it there. And the other thing is going forward, better engagement with clinical and ward staff is another opportunity. Thank you.
Brilliant. Thank you very much indeed. And room 6.
Hello. In our group, obviously I'll keep it brief because of time. There was a lot of talk around old volunteers really wanting to be able to come back to their roles and feeling it should be their choice about whether or not they choose to take the risk and come in and volunteer. Because that volunteering for them is obviously, that is what they live for. That's what they really want to do. In terms of carrying forward, there was a lot of talk about the training of volunteers, how that's been done online, using online resources, and that is something they very much wanted to be able to continue with. And volunteers themselves have been more open to trying e-learning, whereas perhaps they weren't before. And there's been a lot more recognition of the importance of volunteers and them being a vital part of the team. And I'll leave it at that for mine.
Thank you, Yvette. That's really helpful. Just got 3 more to go. Room 7.
That's me. Yeah, so we focused on the 3 action points as to how people are thinking about preparing for a possible second wave and combining that with the winter pressures work. So I think everyone agreed that there was great potential to capitalise on the successes that have been achieved, which are massive in such a short space of time. So things like the fast track recruitment and onboarding, just general streamlining of processes and procedures. The ability to turn things around quickly, make decisions more quickly. People feel they're more prepared to go forward into the future. People observe that there's more confidence to push boundaries and try things that haven't been tried before because they've been put in a position where there perhaps wasn't much option or it was the best course of action at the time. I think that's pretty much it, really. I mean, most of what we talked about other people have already mentioned, but yeah, general feeling of, although there's been decimation of volunteer services in some cases, there is an appetite to move forward and to look to the future.
Thanks, Sal. Great stuff. And room 8.
Great. We got George and Paul.
Yeah, Alan or Paul was going to feedback.
Yeah, sorry, just found my unmute button.
Good man, well done, Paul.
Me and IT do not go together. Yeah, one of the things that we talked around keeping would be, like everybody else, we lost 90% of our volunteers, but the 10% who hung around and the new expressions of interest that came in, we built a really good close bond. We've worked together. Our relationship is much tighter, much stronger, and with it, their flexibility has been sort of developed as part of their role. So whatever we've asked of them, they've kind of taken it on board and moved forward and embraced it and got on with it. You know, kind of like the introduction of virtual visiting. Would they be happy to pick up iPads and take them across the trust to deliver and make sure whether the patients had the ability to use them and you know, that kind of work. The donations of food from local and national suppliers, they've been on to sort that out, deliver it, make sure it was used appropriately, that kind of thing. So I suppose, so that close bond is there. I suppose it also leads us to a challenge about how we continue that as our existing volunteers and new volunteers come on board. So we're looking to, we've already identified those existing volunteers will become mentors, and as we sort of expand back into other areas of the trust, they will move with it and kind of hopefully mentor new volunteers coming in to have that same flexible approach the ability to become mentors themselves. So I'm looking forward to see how that develops, but I'm also kind of a part of me will think I'm going to lose some of that closeness, but you know, the greater good, I suppose. And the thing that we'd like to carry forward is how they've evolved. They've evolved with part of the needs of the trust. They've responded to what the trust has needed at any one particular time. In terms of bringing back, we talked a little bit about the project that we were starting to deliver for Helpforce around the home, but not alone. And I'd sort of said that, well, there's nothing that we'd want to bring back, but actually there is specifically the Home But Not Alone project that we will be bringing back. We've talked about, and particularly talked about sort of the Northern Ireland around having the social care as part of the health service package, if you like. We will certainly be looking to sort of get that kick-started as soon as possible again, and take it right across the trust, not just a few wards where we piloted it. And I suppose just for the future, this kind of buddying mentoring role is the thing that we will take forward from this, and hopefully grow from a position of strength at the minute. And I think that's everything, George, hopefully.
Yeah, that's great. Thanks, Paul.
Great stuff.
Thank you.
Thank you, Paul. Thanks, George. And last but not least, room 9.
Yeah, save the best till last on that front.
Absolutely.
CJ. So we had some very interesting discussions within the time frame, and there was some background noise from the main call, so we will look at getting that sorted for the next gathering. But all praisings for you, praisings for you, V, on all the technicalities. But one thing that we discussed about carrying forward is Catherine from Bradford District and Anita at St Helens, I believe, had mentioned about volunteer drivers. Catherine especially mentioned that it was fantastic to see the volunteers liaising with the estates and facilities. So kind of internal team communications and helping distribute medicine as well. Anita mentioned pharmacy drivers, which was incredibly impressive. So that is something that they would like to carry forward. They are submitting a business case, I believe, at St Helens to continue that. Whether it's still being reviewed I think it's still in action. In terms of volunteering roles that they would like to resume, I think it was Katrina that mentioned about maternity meet and greet, for example. They are doing risk assessments every 3 weeks, but it is something that they would like to put back in place. Just having a look at what Catherine also mentioned about mental health inpatient sites and recovery pathways. That is something that they are looking to increase indefinitely. Just having a look at the notes as well. The plans for the second wave and winter pressures, when we did ask that point, it was silent for a good few seconds, not because of awkwardness. I just think people were kind of pondering as to there's not really any sort of firm plans at the minute, essentially. But there's also, I think it was Elizabeth at NHS Grampian mentioned about being cautious with standing people down again. Should they look at bringing back volunteers if there was ever a need to push back, similar to the travel restrictions at the minute, no one could go to Spain. It would be nice to have that back, similar to the volunteer roles. Just having a look as well. Anita actually raised a very good point that they are doing return to volunteer questionnaires, just giving volunteers, if it is an issue for them to return back, maybe for confidence or any other issues like dependence or work, maybe a Saturday social to give them the platform to come back to the hospital side and talk about any concerns or anything they might have about returning. So Anita was kind enough to say that she would happily share the volunteer questionnaire if anybody was interested.
Yes, please.
And it was also a case, it has been mentioned a lot from the other teams, but about getting senior leadership, the buy-in, etc., or even just having the conversation and being involved in that conversation with the departments starting up again. That could mean that the volunteers could then return as well. So it's just about making sure that the volunteering department are part of the conversations, even at clinical levels as well, that they're factored in. I think I've covered everything, guys, if you are still on the call.
Thank you very much, CJ, and thanks to everyone. I think there's some really good content there in those from those 9 breakout sessions. As I say, we'll make sure that we've got all of this content up and the recordings where they've been made on the Learning Zone. Thank you to our 4 speakers, Alan, George, Fiona and Jane. And thanks to the people who facilitated the discussions as well. It's a new experiment for us, a format like this, using the breakout room. So I hope it's worked. There's probably a few little teething problems, but I hope it's worked and given you an opportunity to perhaps get to know some of your fellow VSMs in trusts and systems a little bit better and expand your network in that way. But certainly we will be grateful to receive any feedback on how this has worked for you so that we can improve on it as we go forward. But thank you all very much. Another shout out for the big thank you. If you want to nominate any volunteers, celebrate what they've done. CJ's got it in reverse behind us, so if you just look at it through a mirror, you should be able to see that. But thanks very much, everyone. We'll wrap up now, and I'm sure Sally and V will share details when the stuff's up on the Learning Network. Thank you very much. Have a great day. Bye now.
Thank you, everyone.
Thanks,
Thank you.
Bye.
Thank
Bye.
you.
Bye.